Okay, so first thing I'd like to just to emphasise that the burden of disease associated with cirrhosis is rising exponentially. It is currently responsible for the 5th most common cause of death in the United Kingdom and the 9th most common in Europe. And one of the features of this patient group is that they have a heightened susceptibility to infection. And ultimately, in terms of end-stage disease, once they've developed cirrhosis, they have a very high propensity to develop multiple organ failure, particularly sepsis. So immunological phenotype is critical to the pathogenesis of this patient group. So this data comes from a very large study called the Canonic study, which looked at over 1,000 patients who were hospitalized with what we call acute decompensation or complications of cirrhosis, and looked at various aspects of their clinical phenotype. And they basically identified that a systemic inflammatory response syndrome, so a highly activated inflammatory response, underpinned and was associated with worse outcome and was associated with the development of organ failure. And it is an independent predictor. So this graph here shows, so it shows that the probability of death at 28 days after admission with an acute complication of cirrhosis increases with white cell count in patients that have multiple organ failure and a background of cirrhosis, a term we call acute on chronic liver failure. What was really interesting is that if you stratify patients by whether they'd previously had a complication of cirrhosis or not, then actually patients who had prior decompensation, so a history of complications of cirrhosis, did better than those who had not. And this had been interpreted as potentially having a heightened susceptibility to a bacterial ligand, particularly endotoxin, may be associated with a worse outcome. And patients that have a history of chronic disease may be more tolerized to endotoxin. So this story is really all about endotoxin sensitivity and how we can potentially modulate that therapeutically. And that's a key message. So we know that in these patients that the innate immune response, that is the early aspects of the immune response, is defective. And broadly speaking, the innate immune response is defective at multiple levels. We were particularly interested in looking at neutrophil function. That's a key aspect of the first line of defense. And what we know from previous studies, if you can see from this Kaplan-Meier curve, so it's quite small, is that if you look at patients and stratify them by if they have a phagocytic capacity of greater or less than 42%, then those with a phagocytic capacity of less than 42% have a worse outcome. And this is in patients with alcoholic hepatitis and cirrhosis. Also, so phagocytosis, the ability to encapsulate and to kill bacteria, the production of something called reactive oxidant species, which is essentially a bit like bleach derived from the neutrophils intended to kill the bacteria, if that is increased by 55%, then the patients are associated with a worse outcome in these patients. So they are both activated in terms of their reactive oxygen species production, but also defective in their ability to clear bacteria. So it's complex. Okay, and what we do know from previous studies that both of these functional defects are mediated by endotoxin. So this graph that you see here, this is looking at patients looking at their neutrophil function. So resting burst is a measure of the reactive oxygen species production. And what you see is if you can remove the endotoxin either with a polymyxin B column or use anti-CD14 antibody to attenuate the effect of the endotoxin, then you reduce that resting burst. That's particularly a feature of patients with a heightened ROS production. So we know that functionally, if you get rid of the endotoxin, that their neutrophil defect can be improved. And this has been a point of interest more recently. Patients have been studied looking at long-term antibiotics. So antibiotics are used in more advanced cirrhosis, particularly the quinolones, and norfloxacin studies have been looked at. And we know that if you give a patient antibiotics such as norfloxacin with advanced disease, then you can improve the 1-year survival. But of course, antibiotics are not the answer in the long term, and of course they're associated with further disturbances in the microbiota and Clostridium difficile, to name just one. And so therefore there's a real need for modulating the microbiome independent of antibiotics mechanisms. Okay. So just thinking about the background, so what is the role of the microbiome in liver disease? Well, broadly speaking, there are two main roles. It is immunogenic, which is what we're going to focus on today, and metabolic. And we've heard a lot about, I'm not going to talk about sort of the metabolic contribution of the microbiome to disease, but we're particularly focusing on the immunogenic role, so by which I mean how the bacterial products themselves stimulate the immune response. And of course, that occurs because bacteria or their bacterial products migrate from the gut in the intraluminal compartment through beyond the gut to more systemically. And of course, the first organ they come across is the liver. And this has been a hypothesis and more than a hypothesis. There's multiple lines of evidence of this process occurring in cirrhosis, and that it occurs more. There is increased bacterial translocation rates with progressive disease. So why does this process occur? Because normally in health, that is not something that we see. So there are three pillars which underpin the process of bacterial translocation, and all three are defective in end-stage cirrhosis. So the first being the gut microbiota, and now with the newer technologies, we are characterising the composition and functionality of the microbiota. And broadly speaking, there is a reduction in diversity, and there are a raft of different metabolic defects that depend on stage and also on the underlying cause of the liver disease. Not least, also nutritional factors and the particularly alcohol and the diet, whether it's high-fat diet, diabetes and cholestasis, so bile salt availability. So all these factors impose selection pressures on the gut microbiota. Also, we know that with progressive disease, with the development of what we call portal hypertension, which is the back pressure which develops as a result of cirrhosis, you get an increased leaky gut. So permeability or leaky gut is increased as you have more advanced disease. So that obviously promotes the translocation of these products. And the final key mechanism is immune surveillance mechanism. So ordinarily, even in health, you will have some degree of translocation from the gut to the liver, but you have a raft of tissue-resident cells which ensure that that is not that does not become systemic. So, but we know that the immune function is defective at multiple levels, and the same is true in the tissue-resident cells in the liver. So all three factors work together. So we really need to be thinking about how we can modulate it. And the hypothesis by using is by targeting the gut microbiota in particular. So any one of these potentially has the possibility to affect change. Now, there are some studies out there, and the background literature is really quite heterogeneous. We know that probiotics have been shown to have positive effects on liver injury in murine models, although that's very dependent on the bacterial species, and of course preclinical models are not always translatable. The microbiology is different in rodent models than in humans. But we do know that in clinical studies that probiotics reduce encephalopathy, have been shown to improve liver biochemistry and outcome after liver transplantation. And there have been some meta-analyses that have supported its use. But as I say, the background literature is heterogeneous. So the premise to our pilot study looking at Lactobacillus casei shirota in cirrhosis patients was based on the fact that we know that the microbiome is pathological with a reduced bacterial diversity. Could we reverse that with a course of probiotics? So the first proof of concept study was an open-label study. It was looking at 12 patients with alcoholic cirrhosis and 8-patient control. And these patients had Child-Pugh-C, but administration of 28 days of probiotics was associated with no adverse events and a good compliance with the patient group, which was an important finding. So, but the main emphasis was looking at how could, if we alter the microbiome, how can we improve neutrophil function? So, turning first to the measure of neutrophil function, which is phagocytosis, so the engulfment of bacteria and killing, we looked at the phagocytic capacity in neutrophils derived from patients with alcoholic cirrhosis. And what you see is that compared to healthy controls, you get a significant reduction in phagocytosis, and we've already mentioned that, but that by day 28, that's significantly improved in patients receiving LCS compared to the patient control groups, which, given the N numbers, was pretty impressive. Looking at the cytokine concentrations, you have two analyses. The first is the constitutive cytokine production, so cytokines, a measure of inflammation in the plasma, and we found that TNF-alpha receptor levels were increased in these patients, that in IL-10, which is an anti-inflammatory cytokine, they were significantly improved. What was more interesting was the fact that the probiotics seemed to have a disproportionate effect in terms of LPS-induced cytokine production. So this was whole blood that was challenged with endotoxin and then looked at the cytokines. And what you see is TNF receptors and IL-10 cytokine concentrations are increased, but all three were significantly improved. And what that tells you with probiotics, it suggests that the whole blood the probiotics has reversed the priming in this patient group to endotoxin challenge. So this was quite an important finding, and it was really novel that we're using a single species and in this patient group, and if we had modulated the innate immune function, could we affect a greater change by a longer duration of treatment, and could we see how that effect, whether that effect was observed in patients with non-alcoholic etiologies as well. So that led to us performing this study, which was a double-blind, multi-center randomized placebo-controlled trial of Lactobacillus casei shirota in stable cirrhotic patients. So we looked at 92 patients in this group. The inclusion criteria were including up to early Child-Pugh-C cirrhosis, so up to advanced cirrhosis. And we looked in 2 UK centres, and these patients received 65 mils of LCS 3 times a day for 6 months. And the placebo group obviously received the same placebo. The patients, we stratified them because of the proof of concept data was based on alcoholic cirrhosis. We stratified to alcoholic etiology and non-alcoholic etiology because we know that alcohol has a disproportionate effect on the microbiome, so we wanted to consider those two groups separately. So the patients were treated for 6 months and they were assessed at those time points. So I've already rehearsed this hypothesis. The hypothesis was that we would restore innate immune function by improving the microbiome, but we also needed to look at the measure of gut barrier integrity. And we wanted to see if this correlated with a significant improvement in the rate of infection and complications of cirrhosis. So our primary endpoints related to neutrophil function and sepsis rates, and secondary endpoints related to integrity of the gut barrier, the inflammatory phenotype, and thirdly, the quality of life. So we included the patients' pretty typical inclusion criteria, but they were abstinent for alcohol for up to 2 weeks prior to screening. And these are broad exclusion criteria that might apply to many microbiome studies to try and to account for potential co-founders. So we looked, in terms of the neutrophil assays, we looked at specifically at neutrophils, isolated them, and looked at 4 different measures of neutrophil function to try and ascertain the endotoxin sensitivity, and also in terms of reactive oxygen species production and also phagocytosis. So there were 5 outputs in terms of neutrophil function. We also looked at the cytokines. We measured endotoxin in the serum, bacterial PCR, and we also measured gut permeability by looking at sugar probes, so lactulose, rhamnose, xylose assays. This is our consult diagram. Just broadly speaking, there were no SAEs related to the product, and there were same SAE rates in both groups. So looking at the patient characteristics, this is quite important to highlight to interpret the data. Broadly speaking, the underlying etiology is we stratified by alcohol 50-50. Sort of the remaining non-alcoholic group, there was 40% NASH, but 40% viral hepatitis and 20% other. The vast majority of patients that we recruited were Child-Pugh A, and that was partly because the exclusion criteria prevent us from using antibiotics, and some of our patients with more advanced disease are on antibiotics as standard of care. So this is really important. So these patients are the wellest group in this population, and there are no significant differences in previous decompensation rates. So pretty evenly matched group. When we looked at infective episodes, which were part of our primary outcome data, the frequency was pretty low, and as you can see, these are all different types of infections that we were keen to identify separately. SBP is a condition where bacterial overgrowth in the gut leads to infection in the fluid in the abdomen, and that's associated with a high mortality. But as you can see, none of either of the group has any episodes of SBP in the 6 months, and in a way, these patients did not have ascites, so they can't develop that infection. So when the baseline frequency of these events is very low. Also, the baseline frequency of other infections, such as respiratory tract infections, urinary tract infections, is very low. And in short, there were no significant differences between the group. In terms of what we call decompensation episodes, or these are clinical manifestations of complications of cirrhosis, there were no significant differences between the group in those. And as you see, the frequency of these events is low because they're relatively well population. We look at a raft of blood tests, but there is no clinically significant differences in blood tests between the two. And that include inflammatory indices. And at the time, there was a bit of concern about the role of probiotics and pancreatitis, so we measured amylase with no significant difference between that, and certainly no events of pancreatitis. So turning to our neutrophil function, I'm sorry, this is probably quite a busy slide. We looked at 5 different measures of neutrophil function, and in one of them, we saw a significant difference following 6 months of treatment in the treatment group versus placebo. What does this mean? Well, the PMA-induced ROS is a measure of neutrophil exhaustion. We know that this is a parameter which is associated with increased mortality in patients with we call acute decompensation, or patients hospitalised for a complication of cirrhosis and multi-organ failure associated with that. So it's an important independent parameter, and it's, as I say, of immune exhaustion, and that was significantly improved, perhaps suggesting that there was a less senescent state of the neutrophils, and they had a greater capacity to produce reactive oxygen species. But we did not see the same effects on phagocytosis as we saw in the pilot study. We looked at systemic measures of bacterial translocation, so bacterial DNA in the blood, and also endotoxin, but there was no significant difference between those two. And in terms of intestinal permeability, well, all of the patients had intestinal permeability measures that were within normal range. So again, because they had Child-Pugh cirrhosis. We looked at a panel of about 17 cytokines, and I've just shown 12 here, but in the entire population, after 6 months of treatment, we saw a significant improvement in MCP1. Now, MCP1 is an important cytokine that's produced from monocytes and macrophages, and we know that it is associated with polymorphisms of this gene are associated with spontaneous bacterial peritonitis and also mortality. So this is an important has an important clinical correlate in these patient group, and we saw a significant improvement in that in all patients, but no significant differences in any of the other cytokines. When you stratify by etiology and you look at the alcoholic subgroup, then again, just one cytokine over and beyond the MCP1 was significantly different, and that was IL-1 beta. And if you know anything about IL-1, it has a key role in the inflammasome, in inflammation. Alcoholic hepatitis, alcoholic cirrhosis is a very pro-inflammatory state, and so the fact that we could significantly improve the IL-1 beta in this group is really important. We know from data in knockout mice that this has a key role. So again, has a clinical correlate based on the studies. We are modulating an important cytokine, but we do not modulate the others. In the non-alcoholic subgroup, then we saw significant improvements in IL-117A, which is sort of mucosal derived, and also in MIP-1 beta. In terms of quality of life data, there were no significant differences between the two. We also conducted metabolomic analysis looking at NMR spectroscopy of the urine, but there was no class differences, so there was no signal in the urine that differentiated treatment from non-treatment. So taking all that together, what does it mean? So we observed in a patient group with very early cirrhosis that we see a significant but subclinical improvement in neutrophil function and cytokine profile after 6 months of treatment, and that there was a differential effect in alcoholic and non-alcoholic etiologies, suggestive that, you know, the underlying cause of liver disease, I mean, these are different phenotypes in terms of the microbiome. We don't see a difference in clinical events, but as you see, the baseline frequency of clinical events is very low. So it's and certainly no serious infective episodes were observed in either group across the study. We didn't see an effect on markers of distant bacterial translocation, such as endotoxin or bacterial DNA, but the fact that we are observing an immunological phenomenon suggests that maybe the LCS is exerting an effect more locally in the gut microbiome, and you know, maybe part of an improvement in picture that if you were to translate that into more advanced disease may translate into a clinically significant effect. And moreover, we know that LCS is safe in stable cirrhosis, which is an important output as well. And, you know, there is an argument for evaluating this in more advanced disease now that we have this data. So just finally, just want to acknowledge the whole raft of individuals who have been involved in this study, which from its inception has been very involved, and I'd just like to thank Yakult in particular for funding this work. And thank you for your attention.